And now another edition of Plugged into Long Island, a service of Cox Media Group Long Island. Stay tuned for our first segment after this.
It feels like you're frozen, petrified. You're struggling with your mortgage payments. The bills begin to pile up. Not knowing what to do, you do nothing at all. And that's the worst thing you can do. Because if you take action, if you do something about your mortgage problems, you're far more likely to get the most positive outcome. Making Home Affordable is a free government program. Call 888-995-HOPE to talk one-on-one with a housing expert about the options that are right for you. Real help, real answers, right now. Call 888-995-HOPE or visit makinghomeaffordable.gov. And do something about your mortgage problems. Brought to you by the U.S. Treasury, HUD, and the Ad Council.
Dad! Come on! Over here! Look at this, Dad! Over! Whoa.
The moment my son saw a redwood tree.
It's huge!
Is the moment I knew that for him,
you can't even see the top of that thing.
even the sky has no limit.
There are some moments only the forest can inspire. Find yours at discovertheforest.org. Learn about forests near you and discover cool things to do when you go, like hiking, biking, fishing, or camping. Or do your own thing when you get there with family and friends. Your moment is out there. Find it at discovertheforest.org. That's discovertheforest.org.
Brought to you by the U.S. Forest Service and the Ad Council.
This is the sound of a flat-screen television hurled off a building. Now the new bike your kid wants. These are the things you could have, all cast into oblivion. Because when you throw away money on wasted electricity, you throw away everything you could have bought with it. Use Energy Star light bulbs and appliances, and you could save hundreds of dollars a year. Saving energy saves you money. Learn more at EnergySavers.gov. Brought to you by the U.S. Department of Energy and the Ad Council.
The following interview is with Dr. Kapoor, President of Advanced Urology Centers of New York and Clinical Associate Professor of Urology at the Icahn School of Medicine at Mount Sinai.
Good morning and welcome to Plugged into Long Island on 102.3 WBAB and 106.1 BLI. I'm Al Levine, and I'm here today with Associate Clinical Professor of Urology at Icahn School of Medicine at Mount Sinai, Deepak Kapoor. Good morning.
Good morning.
How are
thanks
you?
for having me. I'm doing very well, and thanks for having me out today.
So we're talking today about urology, but more specifically prostate cancer. And September is Prostate Awareness Month. So we're here to spread awareness this morning, I suppose.
That's correct. You know, there's a lot of controversy surrounding prostate cancer in the recent past, and hopefully we can try to shed some light and clear up some of the confusion that exists regarding prostate cancer and prostate cancer screening.
Are there misconceptions that you can think of off the top of your head?
Absolutely. The United States Preventative Service Task Force issued some guidelines a few years ago that suggested that routine prostate cancer screening wasn't appropriate for men. And that's really unfortunate because the data that they utilized to come to that conclusion was very flawed information that was contradictory and based on short-term follow-up data. More recent studies have come out that have clearly indicated that prostate cancer screening saves lives. The largest study that's been done on prostate cancer screening was in Europe, known as the European Randomized Screening for Prostate Cancer Trial. And in that study, it found that routine screening of men over age 50 reduced the death rate of prostate cancer by 60%. Wow. And even if you start screening at age 60, the death rate from prostate cancer declined by 20%.
Wow, that's pretty significant. So what are some warning signs that men would interpret as a problem?
Well, the problem is that the symptoms that people associate with prostate illness are usually urinary symptoms, such as voiding dysfunction, urinating too often, waking up at night to urinate, perhaps a weak urinary stream, and so forth. The problem is that all those findings are very nonspecific and are generally more associated with a condition known as benign prostatic hyperplasia, or BPH, which is a non-malignant lesion. The simple fact is that the most common symptom of prostate cancer is no symptoms whatsoever. So if you don't proactively look for prostate cancer, by the time it becomes symptomatic, it is probably already spread and your opportunity for cure is lost.
Mm-hmm. What are the opportunities for cure? What are the percentages in successful treatment?
Well, that's the real tragedy, is the fact that virtually all prostate cancer, if it's caught early enough, can be cured. And again, the way to detect prostate cancer is via a simple blood test and a physical examination. There's essentially no risk to prostate cancer screening. All prostate cancer screening does is it gives people a piece of information that they can then discuss with their physician. So once the decision to screen is not the same thing as choosing to biopsy, which is not the same thing as choosing to have treatment. So it's very important that people differentiate screening for prostate cancer with the diagnosis and treatment of prostate cancer, which are really fundamentally different processes.
Mm-hmm. What is the screening process like exactly? I know there are a lot of men out there right now thinking, oh, God, I don't want to go through this. How simple is it to screen? It
really is very simple. The USPSTF was talking about a simple blood test screening, which is known as a PSA, which is prostate-specific antigen. Now, it's important to understand that prostate-specific antigen is prostate-specific, but it's not prostate cancer-specific. Mm-hmm. So that means that you have to interpret the PSA in the context of the patient's overall risk and what other diseases or what we call comorbidities may be existing at the same time. So having an abnormal PSA does not automatically mean that you have prostate cancer. It just means that you should have a conversation with your physician about what your next steps are after that.
Okay. So it is basically a blood test.
Correct. And usually what's done with a blood test is a simple physical examination known as a digital rectal exam, where we feel the prostate as well for any nodules, because unfortunately just a little bit under a third of prostate cancers that present actually have normal blood tests as well. Some cancers don't make PSA, so it's important that you combine the blood test with a physical exam at the same time.
Okay, so the nodule is another indicator, I guess, of the condition.
Absolutely.
How often should they screen for this?
Well, that's really an important question because, and it's very important for men to understand that it's not really a one-size-fits-all process. That screening for prostate cancer really needs to be customized to the individual patient. Mm-hmm. So nowadays we recognize that the most important thing for us to do is establish a baseline PSA for men sometime in their 40s. Now, we found that with longitudinal data that men that have a baseline PSA that's under 1.5, that their lifetime risk of developing prostate cancer is really relatively nominal, unless they have very specific risk factors for prostate cancer. Now, the risk factors that we've identified that are the most significant are, number one, having a family history of prostate cancer, number two, being of African-American descent, and number three, there's a suggestion that exposure to Agent Orange for some of our veterans that served in Vietnam may also be a risk factor for prostate cancer. So once you establish your baseline PSA, then depending on what your baseline PSA is, in the context of whatever other risk factors that you have, you may need to be seen in 6 months. You may be seen for a year. For example, I saw a 46-year-old gentleman yesterday that had no risk factors for prostate cancer whatsoever. His baseline PSA was less than 1. I told him, come back in 4 years for your next checkup. So it really is something that we customize to every individual patient. That's why having a conversation with your physician about prostate cancer testing is so important. Mm-hmm. That was the big danger and what we talked about earlier, Al, about the controversies. The USPSTF tried to apply a one-size-fits-all solution to every man. Mm-hmm. No man should have prostate cancer screening. Well, obviously, that's ridiculous. What about a person with a family history? What about a person with a markedly elevated baseline PSA? What about the African American man that is at risk? I'll tell you a true fact. When the USPSTF, which is a part of the executive branch of the federal government, when they issued their guidelines saying that no man should have prostate cancer screening done, including African Americans, the very next week, President Barack Obama had screening for prostate cancer. So what I would say is that if it's good enough for the President of the United States, then it's good enough for every other man in the country as well.
There you go. Are there other conditions of the prostate that randomly come up in conversation during a medical procedure?
Absolutely. So some of the other things that we can detect with prostate cancer screening are situations such as the benign enlargement of the prostate, other things that can produce a false elevation of PSA besides an enlarged prostate is conditions such as prostate infections known as prostatitis. So there's a variety of other ailments that will come up during a simple history and physical examination when you're speaking to your physician.
Do they factor in at all toward the consideration of the possibility of prostate cancer later? I guess they could, right?
Well, not typically. So the way I describe it to my patients is to think of prostate cancer and benign prostate disease and other things like different trees that grow in the same garden.
Okay,
that they may be related to each other, but they're really not the same thing. There is some evidence that suggests that chronic inflammatory conditions of the prostate may increase your risk for prostate cancer, but the data on that is not is certainly far from definitive.
Okay, we're diagnosed with some form of prostate cancer. What are some of the treatment options there?
Well, this is an area of great interest in research right now. We know for a fact that prostate cancer is a different disease for different men. We grade prostate cancer on a scale of 2 to 10, with 2 being the best, if there's such a thing as a best cancer, and 10 being the worst. And in addition to that, we measure the volume of the cancer that exists in the prostate. So the volume of cancer that exists when we diagnose it is known as stage. The severity of the cancer, if you will, is known as grade. And those two things we factor together. Now, all clinicians that treat prostate cancer are aware that not every patient that has prostate cancer needs to be immediately treated for prostate cancer. That being said, and this is where some of the confusion about treatment arises, because many people are convinced that prostate cancer is an indolent process that you can live with and not worry about. And nothing could be further from the truth, Al. The fact is that prostate cancer is the second leading cause of cancer death in the United States. Even with all our advances, a man dies every 30 minutes of prostate cancer in this country.
No kidding.
So
wow.
It's very significant. Prostate cancer is the most common non-skin solid tumor that's diagnosed in men, and nearly 200,000 men will be diagnosed with cancer every year. So obviously, if we're having about 30-some-odd thousand deaths with 200,000 diagnoses, your lifetime risk of dying from prostate cancer is still very, very substantial. So the important thing is that we know that not all men who are diagnosed with prostate cancer need to be treated immediately. The difficulty is trying to differentiate those men that need immediate treatment for those men that don't. And so we use a variety of tools to stratify patients' risk. More recently, we have some very sophisticated molecular tests that enable us to try to predict which men are going to have more aggressive disease that will spread to other organs and could prove fatal, compared to those diseases that will stay organ confined and really not be as problematic. So the options range from a process that we call active surveillance. Now, active surveillance is not the same thing as ignoring the prostate. It means we're proactively watching the prostate. We're making the decision not to treat the cancer immediately, but we're going to follow it closely over time. And if it shows any evidence of turning into a bad actor, if you will, we'll intervene at that time. So that's one option. Another option that exists is surgery for the prostate. For men that have a lot of years at risk that the cancer appears to be organ confined, we can do an operation that's known as a radical prostatectomy. Now, recent advances in radical prostatectomy, including laparoscopic and robotic techniques, enable us to remove the prostate gland and significantly shorten the blood loss complications and hospital stay that was historically associated with surgery. So that's a good option, particularly for patients that have more than 10 years at risk, younger patients. Mm-hmm. We also have options such as radiation therapy. Historically, we used to do a lot of what are known as seed implantations. We don't do them quite as often anymore because even though they have the advantage of being a one-time deal, you only have to do it once and then you're done with it. The complication rate associated with seed implantation in terms of urinary side effects are more significant than some of the other treatment options. Mm-hmm. In addition, more recent data shows that for more intermediate to high-risk cancer, that seed implantation may not be as effective as other options. We also have treatment options such as external beam radiation therapy. By delivering computer-guided radiation, we can specifically target the prostate and minimize damage to surrounding organs, and that produces a very effective, very reproducible cure rate. And of course, we're doing novel treatment options as well. We're studying the options of doing focal therapy of the prostate, where we only treat portions of the prostate that we identify cancer in, because using new technology such as MRI fusion biopsies, we're able to map the cancer much more accurately and in a more sophisticated fashion than in the past. So it's opening up whole new exciting avenues of treatment that may allow us to kill cancer and really reduce any potential side effects that are associated with it.
So there's been a lot of development recently, I suppose, in this
Absolutely.
This
area. Oh, it's tremendous. So if you take a look at when the history of prostate cancer treatment, if you look in the 1970s, nearly a quarter of men who presented with prostate cancer presented with disease that had already spread to the bone, that was metastatic. Those men, once the cancer is out of the prostate, the opportunity for cure is lost. So the 10-year survival for prostate cancer in the 1970s was 50%. The 10-year survival for prostate cancer now is 98.9%.
Wow.
Okay? So that's absolutely dramatic. The number of the death rate for prostate cancer over the last 2 decades has declined by 38%. So the strides that we've made have been absolutely tremendous, and all those strides can be attributed to the fact that these wonderful new treatment modalities that we have, we're able to deliver them to patients earlier in the disease process. Now, again, there clearly is a subset of men that we can defer immediate therapy for. But the point is, we have to identify the presence of disease. So as a male, putting your head in the sand and saying, oh, if I have prostate cancer, I don't need to be treated. Well, that's just simply not true. Again, 30,000 men every year make that mistake and die of their disease. So the important thing for the listeners to be aware of is that you can't find prostate cancer unless you look for it. And if we do find prostate cancer, it's by no means a death sentence. There are really tremendous treatment options that can treat the disease in a safe and effective fashion.
So the issue now is more spreading this awareness than it is the actual percentage of success in treatment.
That's absolutely right. It's one of the things that is so frustrating as a physician to have these tremendous treatment options available and still see men that are not getting screened for their disease. So when you see somebody that comes in that has elected not to have their screenings done or has deferred it or put it off or been afraid, and they present with advanced disease and go on to succumb, it's really tragic because that's a death that was definitely preventable. So that's one of the things that the listeners should be aware of. Coming up in September is Prostate Cancer Awareness Month, and this is when pretty much everybody that's involved in the treatment of prostate cancer, from the physicians in the urological community to pharmaceutical companies to different vendors that are involved in treating the disease, band together to try to encourage men to take this opportunity to get screened. There'll be a number of free screenings that are going to be done. We have a not-for-profit foundation that we work with, the Integrated Medical Foundation. They have their website, www.imfcares.com. So people can go to their website and look for screenings. Certainly the American Cancer Society, other organizations support screening. Our practice, Integrated Medical Professionals, which is working with Advanced Urology Centers of New York and Advanced Radiation Centers of New York, have partnered with Henry Schein this year to sponsor screening events throughout the New York metropolitan area. So the opportunity to have access to free screening during the month of September, it's really the best time of the year. What we like to tell folks is that as everybody gets ready for back to school, put a prostate checkup on the back to school checklist for Dad.
Makes sense, and it's so simple too. It really doesn't take much time, and it's probably painless, right?
Yeah, the physical examination has a minor bit of discomfort associated with it. Nobody likes the idea of having the quote finger wave done.
Right.
But the fact is that it is a very brief investment.
It's very important. Yeah.
For really a lifetime of peace of mind.
And it's quick. It's really fast.
It really is.
We're speaking with Dr. Deepak Kapoor. He's the Associate Clinical Professor of Urology. Doctor, let's talk a little more about advanced prostate cancer and the treatment for that. Say someone's held out for too long, or maybe they've had initial treatment, but this has continued to grow. What are some options there?
Well, Al, I'm really glad you brought that point up, because the treatment options for advanced prostate cancer have really undergone a metamorphosis in the last few years. We've always had the ability to treat advanced prostate cancer with hormone therapy. Prostate cancer requires testosterone as a substrate, which, to put it simply, testosterone could be considered the food for prostate cancer cells.
Okay.
So we've known since the 1940s, if we take testosterone away, the patients can have a pretty good length of survival with hormone therapy alone. The problem is that once hormone therapy fails, we historically have had nothing to offer patients. Now, happily, it's only been in the last 5 years that's changed. It started with a drug known as Provenge, and we were very proud at Advanced Urology Centers of New York to be one of the pioneers in this therapy, which is a agent that actually activates the body's own immune system to fight cancer cells. So that was the first one of the agents that came out. Since then, we've had the development of some oral agents that you could take by mouth that help, and there's some novel radiation treatments as well. So, for example, there's an agent called Xofigo, which we've treated more patients than anybody in New York State with patients with advanced bony disease, can reduce pain and extend survival. And we're really happy at Advanced Radiation Centers of New York to be one of the pioneer sites for a prostate cancer vaccine known as Prostate that actually can prevent recurrence of prostate cancer as well. So although certainly we want to focus on getting patients screened and treated early, those patients with advanced disease, there's more hope for them now than there has ever been.
So the main theme here is get screened. And we have the Awareness Month coming up for prostate cancer. It's a very simple process. You want to give the website address again for locations and beginning activities to get that started?
Absolutely. So for screening sites, you could look up the Integrated Medical Foundation. That's www.imfcares.com. And, of course, for any information on any type of urological disease, people can feel free to go to our website. That's www.aucofny.com.
Speaking with Dr. Deepak Kapoor today about prostate cancer. So prostate cancer awareness coming up the month, September. Get it on the calendar. And any closing thoughts here?
Al, first again, I want to thank you for having me out to talk to your listeners about this important issue, and just want to stress to everybody that prostate cancer screening is a very benign and safe process, that I want to encourage men to talk to their doctors about prostate cancer, and even more importantly, I want to encourage the families of men that they love, because a lot of times men are not that good about taking care of themselves. So the wives and daughters and nieces and granddaughters out there, talk to the men in your life about getting screened, because what everybody needs to be aware is that early detection saves lives.
And this is simple, quick, fairly painless. It is painless. It's really easy, and it's so important. So get it done. Thank you for being our guest today.
Thanks again for having me.
You've been listening to Plug Into Long Island on 102.3 WBAB and 106.1 BLI.